All right, so we're reading ophthalmology and hopefully we'll have enough time to go through ENT as well. All right, so ophthalm. This figure illustrates common visual defect and the anatomic areas with which they are associated. So hordeolum, this is a painful abscess of the eyelid, also called the stye, caused by infection of a sebaceous gland located around the eyelash, z's and mole, or inner lid margin, like Mobian. Um, S. aureus is the most common pathogen. Hordeolum presents with localized swelling and erythema. Initial management consists of warm, moist compresses, topical antibiotics, steroid ointments, and lid massage several times a day to facilitate drainage. Refractory hordeola may be referred to ophthalmologists for incision and drainage. Chalazion. This is a granulomatous lesion of the eyelid that presents with localized swelling and a non-tender hard nodule, differentiated from a hordeolum by a comparative lack of erythema and pain. Management includes warm compresses, topical antibiotic and steroid combination, and also possible incision and drainage. Refractory lesions. This is the lesion chart. Okay, so we have eye. If there's a lesion here, we'll have a central scotoma. If we have a lesion here on the left side, the left eye will have optic nerve, left anopia. Okay, this is the right. So this is the optic nerve. This was the macula. So if we have it on the left eye, on the left side, we'll have a left scotoma, right? And then here, optic nerve, then left anopia. If we have one on optic chiasm, then it's going to be bitemporal hemianopia, okay? So this goes like this. So it's going to black out this stuff because remember, it's the opposites, right? Okay, so bitemporal hemianopia. Optic tract, okay? So yeah, so temporal sides are gone when it happens in the middle. Okay, so you can still see in the middle portion of the eye field, media portion. Sorry. Okay, so optic tract down here is going to be. So if it's on the left side, um, you'll have a right homonymous hemianopia. Okay, so if it's on the left side, your right side is going to be gone. Right. Mare loop. Right. So it's on the opposite side. So if it's on the left side, then it's the right. If it's in the right side, then you get the left homonymous hemianopia. 5 is mare loop. This is left parietal lesion. Okay, so again, we're on the left side, so it's going to be on the right. Um, and I remember, like, if it's lower, then you get the upper. Okay. Um, or hold on, no. Since it's on the top side, if we consider this the bottom and this the top, then it's on the top side, and if it's on the left, then the right quadrant is the one that's going to be affected. Here it's at the bottom, so it's going to be the bottom one's affected, and it's on the left, so the right quadrants are going to be affected. This is called right upper quadrant anopia, left parietal lesion. Okay, so if you have a parietal lesion, that's the one. And then we have dorsal optic radiation, right lower quadrantonopia. This is left temporal lesion. If posterior cerebral artery infarct, visual cortex. Okay, so that's important. If you see something like this, chances are it's a PCA infarct. Right hemianopia with macular sparing. This is um, classic to this, right? So again, one more time. This was in the macula. This is optic nerve. This is optic chiasm. This is optic tract. This was the Mayer loop. This is the dorsal. Mayer loop was left parietal lesion. Dorsal optic radiation. That's the left temporal lesion. And then we have posterior cerebral artery infarct. Right. So visual cortex, and we have the macular sparing over there. Okay. What was the question here? 61-year-old man presents to the emergency department with a 6-month history of progressively worsening nausea and morning headache. The patient is in no apparent acute distress. What is the preferred diagnostic study? Okay. The patient presents with symptoms that are concerning for increased ICP as he is not in acute distress. MRI is the preferred study because it is better for visualizing soft tissue and vascularity. Okay, not part of the opto stuff, but okay. So this is called blepharitis. Okay, blepharitis, and that's uveitis, I believe. If they, nope, that was corneal abrasion. Okay, and B, this is Woodlamp's examination with corneal abrasion. Do that for syphilis, I think. Okay, chronic inflammatory blepharitis. So a chronic inflammatory condition of the eyelash follicles, anterior or Mobian glands, posterior of the eyelids, producing lid irritation that may lead to erythema and pruritus of the eyelid or conjunctiva, excessive tear production, eyelash crusting, and light sensitivity. Initial treatment is with warm compresses, lid hygiene, and lubricating a drop to prevent corneal dryness. Patients who do not respond to initial therapy are treated with topical erythromycin. Oral antibiotics like doxycycline or azithromycin may be useful for refractory cases. Lid hygiene, uh, including washing and avoidance of irritants such as smoke, eye makeup, or contact lenses, emphasized to prevent future symptoms. Corneal abrasion. Damage to the corneal epithelium caused by trauma, including from foreign bodies or contact lenses. Patients report severe eye pain for foreign body sensation and photophobia. Diagnosis is made by fluorescence examination where there is increased uptake of fluorescent stain in the area of abrasion under a wood lamp. Treatment consists of removing any retained foreign body, pain control, and topical antibiotic therapy. Fluoroquinolone drops are used for contact lens wearers due to risk of Pseudomonas infection, whereas erythromycin ointment or polymyxin trimethorphan drops are suitable for patients who do not wear contact lenses. Okay, so Pseudomonas for contact lens wearers. Okay. Preseptal preorbital cellulitis, infection of the eyelid and surrounding soft tissue anterior to the orbital septum, presents with painful erythema and edema of the eyelid. S. aureus is the most common pathogen. Patients with no skin trauma are treated with amoxicillin clavulanic acid, whereas patients with skin trauma are covered with methicillin resistant S. aureus, with the addition of trimethorphan sulfamethoxazole or clindamycin. Okay, let's pay attention to that again. Infections of the eyelid and surrounding soft tissue anterior to the orbital septum. Okay. Presents with painful erythema and edema of the eyelid. S. aureus is the most common pathogen. Okay. So if you have a patient with no skin trauma, they're treated with amoxicillin clavulanate acid or gentamicin. Sorry, augmentin. Sorry. Whereas patients with skin trauma are covered for MRSA with the addition of TMPSMX or clindamycin. Okay. This condition is differentiated from the more serious orbital postseptal cellulitis by lack of ophthalmoplasia, pain with eye movement, or propoptosis. CT of the orbit can be used to differentiate the site of infection in unclear cases. Okay. So you do CT or this, okay. Um, let's do the question. A 24-year-old female with a body mass index of 33 presents with 3-week history of constant retroorbital headache with occasional nausea, vomiting, and tinnitus. She also develops new onset diplopia 2 hours before presentation. On physical examination, she is noted to have papillary edema. What is the most likely diagnosis and what are the risk factors for this condition? Okay, vomiting and all that stuff. So increase intracranial pressure. Yeah, let's see. Oh, it's a tumor. Given this patient's symptoms are risk factors, she probably has pseudotumor cerebri, also known as idiopathic intracranial hypertension. Yep. In intracranial hypertension, some symptoms are suggestive of a brain tumor and CSF pressure will be increased. However, neuroimaging will be normal. Obesity, tetracycline, growth hormone, and excess vitamin A are risk factors for the disease. Obesity, tetracycline, GH, vitamin A. Treatment is with acetazolamide, topiramate, optic nerve fenestration, and ventriculoperitoneal shunt if needed. Orbital postseptal cellulitis. Infection of the ocular muscles or orbital fat sparing the globe that may lead to vision loss or death if left untreated, commonly caused by direct spread of infection from the paranasal sinuses. Other causes include trauma, ophthalmic surgeries, dental infections, and dacryositis. Dacryositis. What? Keratitis. It is usually caused by staphylococci, including MRSA, streptococci, and H. influenza in children. In patients with diabetes and immunocompromised, mucor and rhizopus must be included in the differential diagnosis. History and physical examination presents with acute onset fever, propoptosis, decrease in extraocular movement, ocular pain, and decreased visual acuity. The physician should look for a history of ocular trauma, surgery, or sinusitis. Palatal or nasal mucosal ulceration and coexisting maxillary and or ethmoid sinusitis suggests mucormycosis or rhizopus. Diagnosis mostly clinical. Best initial test is blood and tissue fluid culture. CT scan or MRI of the orbit and sinuses to rule out orbital abscess and intracranial involvement. Treatment here is that the patient should be admitted and administered broad spectrum IV antibiotics such as vancomycin and ceftriaxone. Vancomycin and ceftriaxone. So that's a big one, and ceftriaxone third generation. Okay. Um, Metronidazole is added for intracranial extension. Case requires an ophthalmologic ear, nose, throat consult. Abscess formation or a worsening condition may necessitate surgery. Patients with diabetes or immunocompromised should be treated with amphotericin B and surgical debridement, often associated with cavernous sinus thrombosis, if mucor or rhizopus is diagnosed. Key fact here is orbital cellulitis can be distinguished from preseptal cellulitis by the presence of following clinical features: restricted or painful eye movements, okay, decreased visual acuity, diplopia, propoptosis, and presence of a relative afferent pupillary defect. Okay, so here conjunctivitis, we don't know if it's inside or outside, right? If it's outside, which is this, um, will have restricted or painful eye movements, decrease in visual acuity, diplopia, propoptosis, and presence of relative afferent pupillary defect. If it's on the preseptal cellulitis, then it's going to be these things, which was painful erythema and edema of the eyelid. Okay. Condition is differentiated from the more serious orbital postseptal cellulitis by lack of ophthalmoplasia, pain with eye movement, or propoptosis. Cool. So if you have pain, it's orbital cellulitis. Postseptal, if there's no ophthalmoplasia and you still have all of this stuff, then it's preseptal. Okay. Key fact: Neisseria conjunctivitis is an ocular emergency, often requiring inpatient parenteral antibiotic therapy. Okay, this is dacryositis. Okay, conjunctivitis. An inflammation of the conjunctiva, producing a red appearing eye. It is most often allergic, viral, or bacterial, but can also be fungal, parasitic, or chemical. It is essential to differentiate potential vision threatening infectious etiologies from allergic or other causes of conjunctivitis and to identify other vision threatening conditions that may mimic conjunctivitis. This table lists the common etiologies of infectious conjunctivitis. 2.9, 23, this one, we'll do that. Uh, there's allergic conjunctivitis, bilateral, predominantly itchy eyes, treat with antihistamine, olopatadine, eye drops. Bacterial conjunctivitis, purulent discharge. In bacterial conjunctivitis, you will have purulent discharge. Treat with erythromycin ointment or fluoroquinolone drops in contact lens wearers. Viral conjunctivitis, watery discharge, often bilateral, self-limiting. Okay, so if you have watery discharge, it's probably viral conjunctivitis. Here we have itchy eyes, and it's allergic. Okay, watery discharge, often bilateral, self-limiting. Treat with antihistamine, uh, olopatadine, or lubricating eye drops for symptomatic relief. Acute dacryositis is hmm, um, infection of the lacrimal sac. Okay. Oh, right. Okay. Infection of the lacrimal sac, usually by Staphylococcus or Streptococcus species, may progress to orbital cellulitis or meningitis if left untreated. Okay. Congenital nasolacrimal duct stenosis or dacryocytocele nasolacrimal duct cyst are predisposing conditions. History and physical examination, presentation with purulent eye discharge as well as inflammation overlaying the lacrimal system and medial eyelids, medial canthal region. Less commonly, fever and increase in WBCs. Diagnosis here is clinical diagnosis. Treatment here is, if mild, oral anti-staphylococcus or streptococcus agents. If serious, immediate empiric broad spectrum antibiotics to prevent orbital cellulitis. Okay, so here we have some orbital and viral common causes of infectious conjunctivitis. So in bacterial, staphylococci, streptococci, H or Haemophilus, Pseudomonas, and Margzella. Characteristic is foreign body sensation, purulent discharge. Okay, that's the giveaway. Diagnosis is gram stain and culture if severe, and treatment here is antibiotic drops and ointment, gentamicin, fluoroquinolones, right? What was it? Is uh erythromycin, ointment, and fluoroquinolones. Okay. Neisseria gonorrhea. It is an emergency corneal involvement, can lead to perforation and blindness. Diagnosis: gram stain showing gram negative intracellular diplococci. So IM or IV ceftriaxone. Inpatient treatment if complicated, contact tracing and treat sexual partners as well. We have chlamydia, trachomatis A to C, and trachoma global. Characteristic here is recurrent epithelial keratitis in children, trichiasis, corneal scarring, and entropion. Leading cause of preventable blindness worldwide. Diagnosis clinical, most often PCR, and treatment is azithromycin, single oral dose in mass treatment. And then we have D2K chlamydia, which is characterized as ophthalmia, neonatrum, mucopurulent conjunctivitis in neonates, adult inclusion conjunctivitis, chronic conjunctivitis with mild mucopurulent discharge in adults. Diagnosis is ophthalmia neonatrum, gem sustain, PCR. Adult inclusion, conjunctivitis, is PCR again. Treatment here is, um, so it was same as this one. So PCR we can do here. Mostly it's clinical, otherwise for A to C. Okay. Treatment here is ophthalmia neonatum, erythromycin, first line, and azithromycin. For adult conjunctivitis, azithromycin, single oral dose, screening for gonorrhea, and contact tracing. And viral, adenovirus, most common. Characteristic, copious watery discharge, severe ocular irritation, preocular lymphadenopathy, pharyngitis with adenovirus, pharyngoconjunctival fever, occurs in epidemics, and treatment is contagious, self-limited. Okay. Herpes simplex keratitis, viral infection of the cornea, common cause of visual impairment in the United States. History and physical examination. Um, okay. Uh, Presents with pain, blurred vision, tearing, and redness. The virus remains dormant along the trigeminal nerve and may reactivate during periods of immunocompromise, such as illness. Diagnosis is typically clinical, however, dendritic ulcers are characteristic. Okay. Epithelial scraping shows multinucleated giant cells. PCR of conjunctival corneal swab for confirmation. Treatment here is oral or topical antiviral treatment. I mean therapy, sorry. Yep. So this is dendritic uh looking thing. What was that? However, dendritic ulcers are characteristic. Okay. So herpes keratitis with dendritic ulcers. So that's what that is. Okay. Uh, Contact lens keratitis, medical emergency often caused by Pseudomonas infection. So happens in people with who wear contact lenses, right? So it is a medical emergency, often caused by Pseudomonas infection. History and physical examination typically presents with painful red eye and opacification and ulceration of the cornea. Most patients report a history of improper contact lens hygiene, such as reusing lens solution or showering, swimming with lenses in. Severe disease can cause corneal perforation and permanent vision loss. Uh, Diagnosis here is clinical. Corneal scraping and bacterial culture are usually performed for antibiotic sensitivity. Treatment here, immediate removal of the contact lens and administration of topical broad spectrum antibiotics. Okay. Uveitis. Uveitis is infectious or non-infectious inflammation of the uvei. Specific name is based on the location within the affected eye. Anterior uveitis, iritis, posterior uveitis, choroiditis, and or retinitis. Affected with systemic inflammatory disorders like sarcoidosis, inflammatory bowel disease, rheumatoid arthritis, juvenile idiopathic arthritis, human leukocyte antigen HLA-B27 associated conditions. History and physical examination of patients with anterior uveitis may have pain and redness of the eye, often worse at the limbus, corneal scleral junction. They may have hypopyon, accumulation of pus, and anterior chamber. Posterior uveitis presents with visual changes such as decreased visual acuity or floaters in the visual fields. Diagnosis is made by slit lamp examination showing leukocytes in the interior chamber, vitreous humor, or other signs of um, inflammation of the retina. Treatment here is treatment of infectious uveitis is targeted towards the specific pathogen. Non-infectious uveitis is treated with topical glucocorticoids. Oral or intraocular glucocorticoids are used for refractory cases. Refractive errors. A common cause of impaired vision correctable with glasses, contact lenses, or refractive surgery. Hyperopia, also called farsightedness, eye too short for refractive power of cornea and lens. This leads to light being focused behind the retina. Correct with convex or converging lenses. Myopia, also called nearsightedness, eye too long for refractive power of cornea and lens. This leads to light being focused in front of the retina. Correct with concave diverging lenses. Astigmatism, irregular curvature of cornea, different refractive power at different axes. Correct with cylindrical lens. Okay. Presbyopia, this is age-related impaired accommodation, focusing on near objects. Okay, so age-related impaired accommodation while focusing on near objects, primarily due to decrease in lens elasticity, changes in lens curvature, and decrease in strength of the ciliary muscles. Patients often need reading glasses or magnifiers. Glaucoma. In the eye, aqueous humor produced by the ciliary body behind the iris travels through the pupil into the anterior chamber and is then drained back into the bloodstream via the trabecular meshwork in the angle of the anterior chamber. Any process that disrupts this natural flow can increase intraocular pressure, damaging the optic nerve head and causing visual field deficits. Glaucoma is the result of such damage in the nerve. Open angle glaucoma is much more common in the United States than closed angle glaucoma. I'll read that again. Glaucoma in the eye, aqueous humor produced by the ciliary body behind the iris travels through the pupil into the anterior chamber. Actually, let me grab a diagram for this. So, got the diagram here. Let's read that again. So, in the eye, aqueous humor produced by the ciliary bodies right here, behind the iris. So, the iris is right here. This is the front cornea. Okay, and lens. Okay, so iris, it goes through the chamber. Okay, so ciliary body behind the iris travels through the pupil into the anterior chamber and is then drained back into the bloodstream via the trabecular meshwork in the angle anterior chamber of the anterior chamber. Any process that disrupts this natural flow, like this, right? This is the closed angle, can increase the intraocular pressure because now it keeps on coming in, but there's no outlet. Oh yeah, outlet is blocked. Okay. Uh, Pressure damaging the optic nerve head and causing visual field deficits. Okay, so this will damage the optic nerve head. Okay, glaucoma is the result of such damage to the nerve. Open angle glaucoma is much more common in the United States than closed angle glaucoma. Closed angle glaucoma headaches are triggered by darkness caused by pupillary dilation. Migraine headaches are triggered by bright lights. Open angle glaucoma generally occurs bilaterally, but closed angle glaucoma usually presents unilaterally. So open glaucoma generally occurs bilaterally, so you're going to find it in both eyes, and whereas closed angle glaucoma is unilateral. Cool. Okay. Cataract. Okay. Lens opacification results in obstructed passage of light associated with diabetes, hypertension, advanced age, and exposure to radiation or corticosteroids. Congenital risk factors: classic galactosemia, galactokinase deficiency, and trisomy 13, 18, 21. That's Patel, Edward, and uh, trisomy 21. Torch infections, for example, rubella, Marfan syndrome, um, Alport syndrome, myotonic dystrophy, and neurofibromatosis too. History and physical examination presents with reduced visual acuity, especially at night, and loss of the red reflex. Treatment here is surgical lens removal and replacement. Oh, they had it here. So from the ciliary, aqueous humor flows through the over the iris right here, from the posterior chamber to the anterior chamber, and then from the anterior chamber it goes through the trabecular meshwork. Right, so there's the normal flow. This is the abnormal aqueous flow right here. So obstructed of drainage pathway. Cool, cool, cool. So finding an open and closed angle glaucoma. So this is the normal optic disc, and this is the cupping. Okay. Cupping, increased cup to disc ratio seen in open angle glaucoma. Okay. Is any? No. Okay. Right. So. Okay. Question. A 39-year-old man presents to the emergency department with severe eye pain, photophobia, and a persistent sensation that something is in his eye. The physician is suspicious of corneal abrasion. What are the risk factors for this condition, and what diagnostic tests can you do to confirm your suspicion? Answer is risk factors for corneal abrasion include trauma, foreign body, and contact lens use. Use a pen light to document pupillary function and the presence absence of a foreign body. A fluorescein examination can be diagnostic and will show a corneal staining defect. Pain persists even after departure of a foreign body due to damage and sensitization of corneal nerves. Okay. Closed angle versus open angle glaucoma. Okay. So in closed angle, etiology is disrupted flow of aqueous humor into the anterior chamber. It results from. Let me get the stuff. Okay. So etiology, disruptive flow of aqueous humor into the anterior chamber results in the increased force in the posterior chamber, leading to angle closure that decreases drainage. Right here, so it presses up against it, so trabecular meshwork pathway is blocked. This ophthalmic emergency can cause blindness. Although this disease usually presents unilaterally, it often affects both eyes sequentially. Okay. So usually unilateral, but often affects both eyes sequentially. Risk factors here are family history, older age, 55 to 70 years, Asian descent, hyperopia, prolonged pupillary dilation, prolonged time in a dark area, stress, medications, anterior uveitis, and lens dislocation. History and physical examination, extreme, sudden onset eye pain, blurry vision, headache, nausea, and vomiting. A hard red eye is seen. The pupil is dilated and non-reactive to light. Diagnosis: best initial test. Ocular tonometry to measure intraocular pressure can quickly provide additional information. Best diagnosis test is assessing the corneal angle with uh, gonioscopy, which is the gold standard. Treatment here is to Treatment is to decrease intraocular pressure. Uses a combination of topical and systemic therapy as follows: eye drop, timolol, epaclonidipine, pilocarpine, um, dorzolamide, and lentanoprost. Systemic medication, oral or IV acetazolamide or IV mannitol. Laser peripheral iridotomy, which creates a hole in the peripheral iris, is curative and can be performed prophylactically. The patient should not have any medications that causes pupillary dilation, atropine, or other medications with anticholinergic activity such as antihistamines and antidepressants. Okay. Open angle glaucoma. Diseased trabecular meshwork results in decreased drainage, leading to gradual increase in IOP and progressive vision loss. Excuse me. Okay. Progressive vision loss. Risk factor: age more than 40 years, family history of open angle glaucoma, black ethnicity, diabetes, and myopia. History of physical examination. Usually asymptomatic until late in the clinical course, when it can cause gradual loss of peripheral vision if left untreated. Cupping of the optic nerve head is seen on fundoscopic examination. Diagnosis. Best initial test is tonometry. Diagnostic test best is ophthalmoscopic visualization of the optic nerve head, enlarged cup to disc ratio, and visual field testing. Treatment here is topical medications such as prostaglandins, lentinoprost, and cholinergic agonists. Pilocarpine increase aqueous outflow, whereas beta blockers, timolol, betoxazole, and carbonic anhydrase inhibitor like acetazolamide decrease aqueous humor production. Alpha agonists, epaclonidine and brimonidine, work via both mechanisms. Prostaglandins or beta blockers are chosen as first line therapy. Okay, so that's important. Prostaglandins and beta blockers, timolol, right? So it's similar in this one, right? So timolol was given as well, and lentinoprost somewhere, right? So there, okay. If medication fails, laser trabeculoplasty or trabeculectomy can improve aqueous drainage. Okay, cool. Age-related macular degeneration. Age-related macular degeneration is more common among white individuals, females, people who smoke, and those with a family history. History and physical examination presents with painless loss of central vision. Okay, so it's going to be painless loss of vision. Early signs include distortion of straight lines, morphopsia, and loss of other aspect of fine visual acuity. Okay. Um, Atrophic dry macular degeneration responsible for 80% of cases. It causes gradual vision loss. Exudative and or neovascular wet macular degeneration much less common but associated with more rapid and severe vision loss. Diagnosis: atrophic dry macular degeneration. Fundoscopy reveals Dursin, accumulation of white yellow extracellular material, and or pigmentary changes. Exudative or neovascular wet macular degeneration, hemorrhagic and subretinal fluid are present. There's a cataract. Okay. Treatment here for atrophic um, AMD, or what's AMD? Atrophic macular degeneration. Oh, age-related macular degeneration, right? Okay. Atrophic age-related macular degeneration. No treatment is currently available, although a combination of vitamins like vitamin C, E, and carotene and zinc has been found to slow disease progression. The physician should be cautious about giving high doses of vitamin E and beta carotene to patients who smoke, as there is an association of increased mortality rate from lung cancer in patients taking high doses of these supplements. Exudative age-related macular degeneration. Intravitreal injections of VEGF inhibitors have been shown to improve vision. Um, Ifilflibercept, ranibizumab, and bevacizumab, or slow visual loss in patients with exudative age-related macular degeneration. So this is a picture of macular degeneration with evidence of Dursin and fibrosis on fundoscopic examination. Cool. Retinal vascular occlusion occurs in older adult patients, and is strongly related to cardiovascular disease. Okay, retinal vascular occlusion. See table 2.925. This one. We'll go through that. Okay. Optic neuritis. Inflammation of the optic nerve that is commonly associated with MS. Okay. Other optic neuropathies may be caused by ischemia, infection post-infection uh, meningitis, encephalitis, vasculitis, connective tissue disease, SLE, Sjogren's, genetic conditions, and drugs. For example, methanol, ethambutol, linezolid, and infliximab. History and physical examination and diagnosis. Optic neuritis produces painful vision loss that is often unilateral. It causes relative afferent pupillary defect, Marcus gun pupil. Okay. Um, Fundoscopy may show disc swelling that looks similar to papillary edema. However, fundoscopy is normal in two-thirds of patients because the inflammation is posterior to the optic nerve head. The diagnosis is clinical based on history and physical examination. Diagnosis may be confirmed with MRI of the orbits. Okay, so optic neuritis, it's a optic nerve inflammation associated with mitral stenosis. Other optic neuropathies may be caused by ischemia, infection, post-infection like meningitis or encephalitis, vasculitis, all those conditions. Okay, and drugs including methanol, ethambutol, linezolid, and infliximab. Key fact for optic neuritis: give IV, not oral corticosteroids. Okay. Treatment here is methylprednisolone IV for 3 days followed by oral steroids. Oral steroids alone may increase risk of recurrence. Most patients gradually recover vision even without treatment, although IV methylprednisolone increases the rate of recovery. Okay, cool. Um, Central retinal artery versus central retinal vein occlusion. So artery occlusion versus vein occlusion is the one with the thunder looking veins. Okay, let's see. So for artery occlusion, history and physical examination is it presents with sudden painless unilateral vision loss, for example, scotoma, as well as relative afferent pupillary defect. Um, Patients who present with a cherry red spot on the fovea, blue arrow in image, retinal swelling, uh, whitish appearance to the nerve fiber layer and retinal arteries that may appear bloodless. Transient occlusion is comparable to the transient ischemic attack and is known as amaurosis fugax. Okay, it's the transient one. Okay, so again, it presents with sudden, painless unilateral vision loss. Okay, so compare that with the vein. Presents with rapid, similar to sudden, painless vision loss. Yes. Variable severity. Okay, so associated with hypertension, and this is a relative afferent pupillary defect. Okay, so it presents with a cherry red spot at the fovea, retinal swelling, whitish appearance of the nerve fiber layer. Okay, and the retinal arteries that may appear bloodless. Transient occlusion is comparable to transient ischemic attack and is known as amaurosis fugax. So cherry red spot is in the artery occlusion. Okay, now gotta remember that the artery causes the cherry red spot. Okay. Etiology. Atherosclerosis is the biggest risk factor. Other risk factors include cardioembolism, atrial fibrillation, endocarditis, giant cell arteritis, Behet syndrome, and sickle cell disease. Workup. Um, Diagnosis is based on history and fundoscopy. The next best test to order after diagnosis are a carotid duplex with echocardiogram to evaluate for atherosclerotic disease and cardioembolic sources. Giant cell arteritis is ruled out using erythrocyte sedimentation. Whoa, give me a sec. Again, Giant cell arteritis is ruled out using erythrocyte sedimentation rate and C-reactive proteins in patients over 50 years who have no visualized retinal emboli. Okay. Treatment here is ocular massage with high flow oxygen administration, intra-arterial thrombolysis within 8 hours. Other treatments target the specific etiology and may include anticoagulation, carotid and arterectomy, and secondary prevention of vascular events such as stroke or MI. Okay, so ocular massage with high flow oxygen administration, intra-arterial thrombolysis within 8 hours. Other treatment target specific etiologies and may include anticoagulation, carotid and arterectomy, and secondary prevention of vascular events such as stroke or MI. So this is the first line, I guess, that you do. Okay. Coming to central retinal vein occlusion, it presents with rapid painless vision loss of variable severity associated with hypertension. A swollen optic disc with hemorrhages, venous stasis, retinal hemorrhages, cotton wool spots, and macular edema may be seen on fundoscopic exam. Okay. Etiology: hypertension is the biggest risk factor. Other risk factors include conditions that cause hypercoagulability, factor V latent, protein C and S deficiency, antithrombin AT3 deficiency, antiphospholipid antibody syndrome, monoclonal gammopathies. Okay, workup is hypercoagulability. Testing should be performed if there is suggestive history or other causes have been excluded. Treatment here is laser photocoagulation for ischemic central retinal vein occlusion to reduce risk of neovascularization. VEGF inhibitors treat macular edema, cause of vision loss in CRVO. Optimization of risk factor treatment, hypertension and diabetes mellitus should occur. Optimization of risk factor treatment like hypertension, DM should occur. Okay, so here we're going to do laser photocoagulability coagulation for ischemic central retinal vein occlusion to reduce risk of neovascularization. Okay, and it looks like that. Okay, etiologies, biggest risk factors are uh, conditions that cause hypercoagulability like factor V lane, protein CNS deficiency, antithrombin deficiency, antiphospholipid antibody syndrome, and that. Okay, we'll get painless vision loss, swollen optic disc with hemorrhages, and this cotton wool spot, macular edema. Okay, retinal detachment, separation of the retina from the underlying retinal pigment epithelium and choroid. Okay, so this is what it looks like. Retinal detachment of fundoscopic examination. I remember in step 1 they used the term curtains closing as an analogy for loss of vision for this. However, that one also can be used for this, the amaurosis fugax or whatever. Okay, so if they give you that the patient explains curtain closing type of vision loss, it could be this or that. If it's transient, it's this, and if it's like for a long time, it could be this, right? But anyways, just wanted to point that out. So separation of the retina from the underlying retinal pigment epithelium and choroid may be caused by retinal tears, proliferative diabetic retinopathy, or trauma. High myopia, more than 6 diopters of correction required, is a risk factor. Sorry. History and physical examination. Sudden onset painless monocular vision loss is often associated with floaters and flashes of light. Visual field defect may resemble a certain ascending or descending over the eye. Retinal detachment and other trauma may cause vitreous hemorrhage, where the vitreous humor fills with blood. This complication presents with black spots and cobweb shape in the visual field. Diagnosis: all patients should have visual field and acuity testing. The detached retina can be seen floating in the posterior chamber of the on ultrasound. Definitive diagnosis requires a dilated fundoscopy exam where the detached retina can be directly visualized. Treatment here is tamponating of the retina via surgery, vitrectomy, or scleral buccal. Key fact: retinal detachment presents with sudden onset flashing lights and blurred vision. Patients typically describe a curtain coming down over their eye. Ophthalmoscopy shows a gray elevated retina. Okay, so that's what I was talking about. Diabetic retinopathy, retinal damage due to chronic hyperglycemia. Two types: non-proliferative and proliferative. Non-proliferative damaged capillaries leak blood, which leads to lipids and fluids seep into retina, causing hemorrhages and macular edema. Treatment here is blood sugar and blood pressure control. Proliferative chronic hypoxia results in new blood vessel formation with resultant traction on retina, which leads to retinal detachment. Treatment here is anti-VEGF injections, peripheral retinal photocoagulation, or surgery. Okay, so just revising this, diabetic retinopathy, retinal damage caused due to chronic hyperglycemia. There are two types: non-proliferative, proliferative. Non-proliferative is the one where the capillaries leak blood, and the way you treat it with is treatment with blood sugar and blood pressure control. In the proliferative one, it's due to chronic hypoxia, so it causes new blood vessel formations. Um, and I remember this from step one, where it usually happens from in little kids, right? Newborns, and then they're put on like oxygen, and they have like multiple vessels forming, and to prevent that, uh, you don't give them a lot of oxygen at once. And here the treatment is anti-VEGF injections, peripheral retinal photocoagulation, or surgery. Hypertensive retinopathy, chronic uncontrolled hypertension, endothelial disruption, fibrinoid necrosis, and retinal damage, flame-shaped retinal hemorrhage, atriovenous nicking, microaneurysms, macular star, cotton wool spots. Uh, presence of papilledema in a hypertensive patient is indicative of malignant hypertension and requires immediate lowering of blood pressure, associated with risk of stroke, CAD, and kidney disease. Okay, dash 43 and dash 43. Which one is this talking about then? 2.9 dash 40. Right? Figure. I don't see no figure. Blue arrow in this. Cotton wool spots. Wrong figure. Presence of that associated with this. Okay. Retinitis pigmentosa, inherited progressive dystrophy of retinitis pigmentosa, or RPE. What was RPE again? Right here. Retinal pigment epithelium. Okay. So, inherited progressive dystrophy of retinal pigment epithelium and photoreceptors. It may be associated with A beta lipoproteinemia. Early findings include nystalopia, night blindness, and peripheral vision loss. Fundoscopy may show triad of optic disc. Okay, paler Optic disc pallor. Okay, so fundoscopy may show triad of optic disc pallor, retinal vein attenuation, and retinal pigmentation with bone specule-shaped deposits. Okay, so basically this, like a moldy little eye. So that's retinitis pigmentosa. Cool. Papilledema, optic disc swelling with blurred disc margin and dilated tortuous retinal veins, usually bilateral, due to increase in intracranial pressure, for example, secondary to mass effect, enlarged blind spot, and elevated optic disc with blurred margin. 2.9, so this one. Okay, so there's papilledema on fundoscopy. Okay, so what we are seeing here is disc swelling with blurred disc margin. Okay, there's no cupping here. And dilated tortuous veins. Okay, dilated tortuous veins. Was it this the one that was thunderous looking? Enlarged blind spots and elevated optic disc with blurred margin. Okay. Leukocoria. That's leukocoria, loss of red reflex. So loss, whitening of the red reflex. Important cause in children include retinoblastoma and congenital cataract. Reflective. Relative afferent pupillary defect, also called Marcus gun pupil. When the light shines into a normal eye, constriction of the ipsilateral direct reflex and contralateral pupil consensual reflex is observed. When the light is then swung to the affected eye side of the optic nerve damage, both pupils dilate instead of constricting due to impaired conduction of the light signal along the injured optic nerve. It is associated with optic neuritis, for example, in multiple sclerosis. Sorry, I think I said mitral stenosis up there. Multiple sclerosis and optic neuropathies, for example, giant cell arteritis. Okay, where did I say mitral? Oh, I think it was in uveitis or something like that. Whatever. Or neuritis, maybe. Whoops. So, Horner's syndrome. This is sympathetic denervation of face causing ptosis, anhidrosis, and meiosis. So ptosis is slight drooping of eyelid, superior tarsal muscle. Anhidrosis is absence of sweating and flushing of affected side of the face. Meiosis is pupil constriction associated with lesions along the sympathetic chain. Right, so this is the sympathetic chain that they're showing here. First neuron, so that's the first neuron right here. Pontine hemorrhage, if it's a lesion can affect, a lesion can be here if due to these causes, so which are pontine hemorrhage, lateral medullary syndrome, or spinal cord lesion above T1. Let's see. Like, for example, Brand-Sequard syndrome or late stage syringomyelia. Okay, so that's what they're trying to say. Okay, so first neuron. And then we have second neuron right here where it crosses. Stellate ganglion compression by Pancoast tumor. So Pancoast tumor can cause a lesion here. And third neuron. So up here is carotid dissection, which is painful, and hydrosis is usually absent if it gets affected here. Okay, so sympathetic chain lesion, spinal cord lesion above T1, which could be Brown-Sequard syndrome, late stage syringomyelia, or lateral-medullary syndrome, or pontine hemorrhage. Okay, so it comes down from hypothalamus down to first neuron, and then synapses in lateral horn, and then from here to this second neuron, and then here superior cervical ganglion, third neuron, and external carotid artery. From here to sweat gland of face, to pupillary dilator, to smooth muscle of eyelid, to sweat glands of forehead. Okay, none of that matters now. Okie dokie. But basically all these. Okay. Orbital blowout fracture. Orbital floor fracture, usually caused by direct trauma to eyeball or intraorbital rim, increases risk of inferior rectus muscle and or orbital fat entrapment. It may lead to infraorbital nerve injury. Cavernous sinus syndrome. Cavernous sinus syndrome presents with variable ophthalmoplegia. Cranial nerve 3 and 4 involve, 6. Cranial nerve 3 and 6 involved most frequently. Decrease in corneal sensation, Horner syndrome, and decreased maxillary sensation. Secondary to pituitary tumor mass effect. Carotid cavernous fistula or cavernous sinus thrombosis related to infection. Okay. Intranuclear ophthalmoplegia. Okay. So now we're talking about these. Anything else I missed out? Nope. Okay. So here, cavernous sinus syndrome. Cavernous sinus syndrome presents with variable ophthalmoplegia. Cranial nerve 3 and 6 are most often frequently involved. Okay. And there's decreased corneal sensation, Horner syndrome, and decreased maxillary sensation. Okay. Secondary to pituitary tumor mass effect. Carotid cavernous fistula or cavernous sinus thrombosis related to infection. We missed out on a period there. Are we missing a page? Nope. Okay. Intranuclear ophthalmoplegia. MLF. Lesions in MLF and direction no term. Okay, so MLF is, okay, so if we are here, neuropathy associated with intranuclear ophthalmoplegia. Pairs of tracts that interconnect cranial nerve 6 and cranial nerve 3. Okay, so this is the one that's responsible for, if this eye looks to the right, then this one needs to look to the left for both eyes to go, to the right as well, so that both can look towards the, hold on, what did I say? If this eye, the right eye needs to go to the left, which is the medial side, this eye is going medially, this eye needs to go laterally to the left, right? So that thing is done by MLF, basically, okay? If one eye is moving laterally, the other eye is also told to move medially towards the same direction, basically. Okay, so a pair of tracts that interconnect cranial nerve 6 and cranial nerve 3. So, yeah. So SO4, LR6. SO4 was superior orbital. That's 4. And LR6, lateral rectus was with the 6th nerve, and then the medial rectus is with the 3rd nerve. Okay. Nuclei. Okay. Coordinates both eyes to move in same horizontal direction. When patient looks left, the left nucleus of cranial nerve 6, right? So LR6, that's the lateral rectus that's innervated by 6 or supplied by the 6th nerve, right? So when patient looks to the left nucleus of the 6th nerve, which contracts the left rectal rectus and stimulates the contralateral right nucleus of the cranial nerve 3 via the right MLF, right? So this one right here, to contract the right medial rectus. Lesions may be unilateral or bilateral. Latter classically seen in multiple sclerosis or stroke. Lesions in MLF. Okay, so that's what MLF was. Now, what if we have a lesion in MLF? That means we'll have intranuclear ophthalmoplegia, or INO, a conjugate horizontal gaze palsy. Lack of communication occurs so that when cranial nerve 6 nucleus activates ipsilateral lateral rectus, the contralateral cranial nerve 3 nucleus does not stimulate the medial rectus to contract. abducting eye displaces nystagmus. So cranial nerve 6 overfires to stimulate cranial nerve 3, right? So you're going to start seeing nystagmus on this side because this one is damaged. This one doesn't know what to do yet, that this one is looking this way. This one's not getting the signal. So this side is going to send to the brain that I'm doing this. Why is this one not doing it? So this one's going to over perform, and then that's what nystagmus comes from, and you get the palsy there. Convergence is normal. So if both are going inwards, it's going to work because that's not through MLF, it's through a different path. Okay. Directional term. For example, right iono, left iono refers to the eye that is unable to adduct. Right. So if this one's going to the left side and the right side is not able to adduct, then we have right iono. Cool. Cool. It's lateral rectus and this, abducting and this. So refers to the eye that is unable to adduct. So if this one cannot adduct with a D, right? So D for delta. Cool. Mnemonic, I know. Ipsilateral adduction with the D, delta, failure. Nystagmus opposite. Right, so ipsilateral adduction and nystagmus on the opposite side. Otitis media. Oh, okay, so we're done with the optal portion. Now we have on Otology. Actually, let's take a break here. Water break or whatever. I'll be back. Otology. Otitis media, acute otitis media. History of physical examination. Pain in the ear, redness, decreased hearing, and fever. On otoscopy, bulging, hypomobile, and decreased light reflex of tympanic membrane are seen. Diagnosis. Best initial test. Usually empirically treated with antibiotics. Consider tympanocentesis with culture in case of recurrent infections. Treatment. Initial best treatment. Amoxicillin for 10 days. If no response, the patient has been treated with amoxicillin recently or symptoms return within 1 month, then amoxicillin clever unit should be used. Okay. So amox or amoxicillin clever unit, also known as augmentin. Okay. For Indian doctors. I don't know if it's here as well. Chronic suppurative otitis media, similar to acute otitis media, except continuous suppuration for more than 6 weeks with tympanic membrane perforation, prolonged duration of symptoms, drainage, pain, and hearing loss, absence of systemic symptoms such as fever. Okay, absence of that. So chronic suppurative otitis media, similar to acute otitis media, except these are the differences, that there's continuous suppression for more than 6 weeks with tympanic membrane perforation, prolonged duration of symptoms like drainage, pain, and hearing loss. Then we have otitis media with effusion, serous otitis media, or glue ear. There's fluid in the middle ear for more than 3 months without an infection. History and physical examination may be asymptomatic, painless, pressure in the ear, post-acute otitis media in children. Otoscopy shows air-filled level behind the bulging tympanic membrane and hypomobility. Okay, so otoscopy shows air fluid level behind the bulging tympanic membrane and hypomobility. Treatment is monitoring for 3 months. If hearing impairment is resulting in speech impairment, tympanostomy tubes may be considered. Question. A 55-year-old man presents to the emergency department with sudden onset headache and dilated pupil in his right eye that is non-reactive to light. His right eye is hard to touch. What is the most likely diagnosis and what medication should be avoided in this patient? Okay, the patient's presentation is consistent with closed angle glaucoma. The physician should avoid pupil dilating medications such as atropine, which will increase intraocular pressure and prevent drainage of aqueous humor. Otitis externa, inflammation of the external auditory canal, also known as swimmer's ear. Pseudomonas and Staphylococcus are the most common etiologic agents. Both grow in the presence of excess moisture. Necrotizing malignant otitis externa, Pseudomonas in more than 95% can lead to otitis, osteomyelitis of the skull base. History and physical examination presents with pain, pruritus of hearing loss, and possible purulent discharge. Examination reveals pain and movement of the movement of the tragus pinna, unlike otitis media, and edematous and erythematous ear canal, and granulation tissue if necrotizing type. Cranial nerve palsies may be visible in the necrotizing type. See the pediatrics chapter for a discussion of otitis media. Diagnosis, a clinical diagnosis, a culture for severe or refractory cases, CT scan if the patient appears toxic. Treatment, best initial treatment, oral toilet, clean and dry ear, for example, using wick and or astringents. Mild otitis externa can be treated with a topical acetic acid 7 to 10 days. Moderate otitis externa is treated with topical antibiotics, ofloxacin or ciprofloxacin, and steroid ear drops. Older adults with diabetes and individuals who are immunocompromised are at risk for necrotizing otitis externa and may require IV antibiotics, usually a fluoroquinolone or fourth generation cephalosporin. Consider Vic placement if occlusion of canal. Okay, sorry. So older adults with diabetes and individuals who are immunocompromised are at risk of necrotizing otitis externa and may require IV antibiotics, usually fluoroquinolones or fourth generation cephalosporin. Consider Vic placement if occlusion of canal. Okay. If to prevent patients should avoid getting moisture in the ear and should thoroughly dry their ears after swimming. Okay. Malignant otitis externa, history and physical examination. Severe examination, infection of the external auditory meatus occurs with ear pain and suppurative drainage. Granulation tissue is seen on otoscopy. Malignant otitis externa is commonly seen in patients with poorly controlled diabetes and individuals who are immunocompromised. Complications include cranial osteomyelitis and facial nerve palsy. The cause is Pseudomonas infection. Treatment is drug of choice IV ciprofloxacin. Other IV antibiotics against Pseudomonas can also be used, like ceftazidime, cefepime, quinolones, azithromycin, piperacillin, and tazobactam. Surgical debridement and biopsy are required with failure to respond to antibiotics. Okay. So this is severe infection of external auditory meatus occurring with ear pain and suppurative discharge. Granulation tissue is seen on otoscopy. In this one, we see that as well, right? External and granulation tissue necrotizing. So how does this differ from this? Malignant otitis externa is commonly seen in patients. Okay, so controlled diabetes, uncontrolled diabetes, and immunocompromised. How about this one? No such thing is stated here about that. Okay. Okay. And here complications include cranial osteomyelitis and facial nerve palsy. That's also there in that one though. But there's suppression here, so there's gonna be some kind of drainage, and here Yeah, this is just oh, there's purulent discharge here as well. Okay, hearing loss as well. Okay, okay. I see. Here, treatment differs in both. Okay, so here we do topical antibiotics, ofloxacin and ciprofloxacin. For moderate, for this one, acetic acid 7 to 10 days for mild, and for adults with compromised immunity, we do IV antibiotic fluoroquinolones or ciprofloxacin. Here we do IV ciprofloxacin right away. Okay, we don't bother with the acetic acid, and for the ofloxacin topical antibiotics, okay, or steroid ear drop, we go straight to IV. Okay. Okay, sensory neural hearing loss. Okay, etiology could be any of these: Meniere's disease, hearing loss, tinnitus, vertigo, and oral fullness due to excessive endolymph in the inner ear. Okay, presbycusis, bilateral symmetric age-related hearing loss to high-frequency sounds due to degenerative changes in the inner ear, and cranial nerve 8. Hearing is worse in noisy environments. Drug-induced hearing loss, noise-induced hearing loss, and acoustic neuroma. Diagnosis: see figure 2.944. Okay. Renan's test, reduced bilaterally. Weber's test, localized to normal ear. Okay, so in sensory neural hearing loss, again, that's the one where it's the cochlea that is not working right for the Renan's test, right? So it's reduced bilaterally, okay. Says in Renan test, okay. Oh, okay, so maybe not the unilateral one that I'm thinking of. Okay. Weber's test, localized to the normal ear. Okay, so it moves laterally to the normal ear. Pure tone audiometry, increased audiometry threshold in air and bone conduction. Other tests include impedance audiometry and otoscopy for visual assessment. Okay, so we have external auditory canal, tympanic membrane. This is the seventh nerve. This is cochlea. Oval window is here. This is seventh nerve vestibule. Ossicles is these blue ones. Incus malleus and stapes. Pharyngotympanic eustachian tube here. Okay. Conductive hearing loss. Renin is going to be abnormal. Weber lateralizes to the affected ear. Because it's conductive, it will go towards the inner ear because the buffering of the air conduction is not there, so it will be better picked up by the bone. That's why it goes to the affected ear. Renin is going to be abnormal. Yes. External ear, outer ear, osteoma, cerumen impaction, and otitis can happen here. In the middle ear, you can have cholesteatoma, tympanic membrane perforation, or osteosclerosis. All of this is going to cause conductive hearing loss. Sensory neural, Renin is going to be normal in sensory neural, and Weber is going to lateralize towards the normal ear. Okay, because since the affected one is not going to convert the signals, so it goes to the one that does, and that's why it's going to lateralize towards that. Internal inner ear, presbycusis. Okay, that's the age-related one. Oh, what's the star for? I don't know. Didn't explain the star. Asterixis. Anyways, presbycusis. This is not because of any damage. I think that's what they want to say. It's bilateral symmetric age-related hearing loss due to high-frequency sounds due to degenerative changes in the inner ear, and the eighth nerve. Hearing is worse in noisy. Hearing is worse in noisy environment. Shouldn't be better. Hearing is better in noisy environment. I think that's what we're trying to see here. Okay. Meniere's disease, acoustic neuroma, ototoxic drugs, and cochlear nerve damage. Conductive hearing loss, etiology, otitis media, acute, chronic, suppurative, serious wax infection, cholesteatoma, uh, growth of keratinizing squamous epithelium, which erodes ear ossicles. On otoscopy, discrete white plaques is seen on the tympanic membrane, and otosclerosis, sclerotic changes in the ear ossicles. Diagnosis, Rennes test, bone is going to be uh, better than the air conduction. Weber's test localized to the affected ear, yes, and pure tone audiometry, increased auditory threshold in air conduction only. And we're done.